all. This is Dr. Mubin Sayed from drbeen.com. Welcome to one more show. My apologies for about month and a half off. I was traveling. So this discussion is about the preprint study from Yale LISTEN study. That was the overall bigger study, out of which a smaller subset is used for this study. This study is labeled in many of the articles as for example, scientists find rare vaccine, post-vaccine syndrome. I think that the very first correction that we should do is to look at the word rare. If we do not have the statistics for how many people do get injured after the vaccination, then calling them rare or numerous, both labels are incorrect. Having said that, the other thing that I saw was that there were a lot of people who were sensationalizing the observations of this study. And I think that truth or reality is stranger than fiction. We do not need to sensationalize these things. We need to actually look at the reality, the truth, the facts that are presented, and look at them to understand what is happening in some people after the vaccine is received. So I had to get into the fray and present my understanding of this study. It is a small study. That can be a criticism of this. There are certain study structures that are absent as well. They may have done them, but they're not in the manuscript. For example, inclusion, exclusion criteria. At least I'm sure that they did it, but at least that is not in the manuscript. Having said that, I'm seeing a lot of people trying to present this data as an equivalent data of HIV-like disease. And that is just completely incorrect, which tells me that sometimes we just, out of our excitement to present something, or maybe sensationalizing it, we jump the gun and start presenting incorrect data. So let's look at this together, and then we'll go from there. So these are gifts for humanity. I had to actually resume them based on some of these studies that we are seeing. Here is the study manuscript here in the PDF form. Immunological and antigenic signatures associated with chronic illnesses after COVID-19 vaccination. And as I said that, this is part of the Yale LISTEN study. As you can see, the affiliations here: Department of Immunology, Yale University School of Medicine, Center for Infection and Immunity, Yale School of Medicine, etc. The lead researcher, I believe, is Kiko Awasaki, PhD, and she has been discussing this with various news outlets as well. Now, starting this whole discussion, this is drbeen.com. If you would like to have more beautiful lectures with CME and CEs, go to drbeen.com and become a member. This is the website, so the medRxiv, where this study preprint is present. I have all these links present in the discussion, in the description of this video. I also am going to refer this study at some point, and that is N1 methyl pseudouridylation of mRNA causes class 1 ribosomal frame shifting. If you remember this discussion that I had done many, many months ago, this study from Oxford, I believe, had demonstrated that sometimes in some people, the ribosomal slippage on the synthetic mRNA causes the production of off-target proteins as well. What is the relevance of that? We'll discuss that as we discuss this study. And because there was a lot of data, I not only drew some, but I also have a PowerPoint as well to kind of quickly go through the points. So once again, reality is stranger than fiction. We do not need to sensationalize this. This is a post-vaccine syndrome. This is a vaccine, after vaccine pathologies that may occur. And that itself, the truth itself, is quite disturbing and worthy of understanding. One more comment before I go into the data is the following. When I said that the inclusion and exclusion criteria were absent, um, I was discussing the same study with some other groups of folks who are part of Patreon and Substack paid members. And I was thinking that in the last 3-4 years, the overall approach of the mainstream medical community has been to shun and to deliberately, passionately suppress or reject or dismiss any vaccine related, injury related discussions. Of course, the studies did not happen, the fundings will not happen, the researchers would probably be stopped. The patients who present that we are injured after the vaccine, you know this, that how they are humiliated everywhere. They do not have support. So in this kind of an environment, I can understand that there is no consensus for what is a post-vaccine syndrome and what is the criteria to diagnose that. So in the absence of that knowledge, there really could not be a very clear inclusion or exclusion criteria other than generalized criteria. For example, somebody is not actively sick, etc., or does not have pre-existing conditions. So as we discuss this study, please keep in mind that the clinical picture of the patients is also important. If you look at vaccine-injured patients or patients with post-vaccine syndrome, that is the language of this manuscript, PVS patients, the patient's symptom set is not that of immunosuppressed patients, which are HIV-like patients who, in HIV, as the disease progresses, the immune system becomes suppressed over time or disabled over time or dysfunctional over time because of lack of the cells, because the T helper cells are infected by the HIV virus and destroyed. In these patients, the vaccine injury patients or post-vaccine syndrome patients, the symptom set is that of dysregulated immune system, is that of overstimulated immune system, is that of autoimmune disease-like immune system behavior. So calling this as a immune suppressed state isn't correct. And so if you know the vaccine injured patients, majority continues to become deteriorated over time. That means the immune system is continuously attacking them and their tissues and damaging them, and that creates deterioration over time. Then there is chronic inflammation present in them. Chronic inflammation cannot be present in someone who has immunosuppressed state. Chronic inflammation means a dysregulated and overactive immune system. Then continuous tissue damage would result in fatigue. That could be direct damage to the muscles. I had done this study in the past that the patients with long COVID, not talking about vaccine injury because very few studies are good studies for the vaccine injury, but long COVID patients who have experienced fatigue, their muscles actually change the muscle fiber types. Similarly, neurological damage can also cause fatigue. Cognitive decline is very common in these patients. Clotting issues are very common, and they do not over time start reducing. Instead, they maintain or increase, which also is an evidence of chronic inflammation, overstimulated, dysregulated immune system instead of a suppressed immune system. Small fiber neuropathies, which causes the patients to have paresthesias, pins and needles, burning sensations, buzzing sensations, hands and feet not working correctly, the feelings of sensations are not correctly, tinnitus occurring. These are all examples of overstimulated, dysregulated immune system and not suppressed immune system. Similarly, flare-ups, these patients actually get flare-ups as well, which also is a wave of overstimulated immune system and more. The point here is to present to you that these patients from their clinical picture is not the picture of HIV or immune suppressed patient. So when we look at the immune phenotype, that is the immune picture, you will see that there are immune cell abnormalities, and I will demonstrate that these abnormalities are not related to suppression. Instead, these are because of dysregulation and overactivity. So starting with these sections, number one, the study overview and the purpose. And this, the first line, the vaccines have saved millions of people, have been safe and effective. I think this is the password to get through the bridge where somebody says, well, you want to pass from here, tell me what is the password. And you say, here's the password. I believe this is kind of disingenuous as well in the for the mainstream media and for the journals to insist that these kind of lines are added. I do not think that understanding science should scare people to the point that they need the safety valves of these kind of statements. Maybe the vaccine injuries are actually rare, but we should actually work on that to figure out how rare. And then if these are rare, then we should work on figuring out who are the ones who have these injuries and then help them and support them. So anyways, that because I'm sticking as usual to the manuscript, I'm just going to present the data from the manuscript. And then wherever I'll present my opinion or my understanding, I would say that clearly that this is my understanding. The study conducted through the Yale LISTEN study analyzed immune profiles, antibody responses, and viral reactivations. Another very interesting thing in terms of the viral reactivation, that some of these vaccine injured patients had EBV reactivation, and some of the immune cell behaviors that you would see are related to EBV reactivation as well. And then finally, this study's objectives were to understand the post-vaccine syndrome patient's immune profile, and then to compare that to the profiles of those who had post-vaccine syndrome, plus who were infected as well. I'm not going to go into the detail of those parts. I just want to bring in some interesting points of the study. So here is the key findings. I think that some of the folks had trouble going over the manuscript and synthesizing the immune system picture together. And that is why they got derailed and thought this was an HIV-like disease. So look, here is what happened. Even before we go to this picture, I want to show you the immune system, my common diagram that I use for all immune-related discussions. Here we have this part is the innate arm of the immune system. Innate arm is the first responder. This has those cells that are non-specific. These cells, for example, macrophages, dendritic cells, monocytes, neutrophils, NK cells, these cells are non-specific. They look at some offending agent and they will attack it and try to clarify that. And that is the innate arm. I have only represented one cell over here, and that is the dendritic cell. Imagine there is a neutrophil over here and a macrophage over there and a monocyte here and an NK cell here as well. The innate arm is the first responder, and once it has responded, it will then activate the adaptive arm as well. Adaptive arm is more specific to a type of antigen or offending agent that has appeared. In this context of the discussion, spike protein, for example. So when the adaptive arm is activated, what happens is that dendritic cell, for example, over here, will, from the innate arm, will pick up the antigen, in this case, let's say spike protein or messenger RNA that may have leaked from a cell, and then take it to the local lymph nodes. Local lymph nodes mean what? If we are talking about the deltoid muscle, where the vaccine is injected, the inflammation that would happen there, the dendritic cells would pick up those inflammatory pieces, the mRNA that is leaking from the cell, from broken cells, or the spike protein that is in there, or the inflamed cell, and they would carry them to the local lymph node, for example, axilla, supraclavicular lymph node, and the lymph nodes in the front of the chest and side of the neck. These are the local lymph nodes that are present closer to the area of infection or inflammation. And over here in the lymph nodes, we'll have T cells and B cells and follicular helper cells and dendritic cells and multiple cells over there. In the context of simple immune diagram, the antigen presented by the dendritic cell will be presented to naive T cells, naive T helper cells or CD4 cells. These cells, once they are exposed to the antigen, then depending upon what is the interleukin present in the environment, if it is interleukin 4 present and interleukin 12 is absent, then a naive T helper cell will become a T helper 2 cell. It is a CD4 positive cell. This T helper 2 cell would in turn release multiple cytokines, but important one for our discussion, interleukin 4 and 5. These would cause the B cells to become converted to plasma cell or become activated. These B cells in turn would start releasing antibodies. And today's discussion, you would actually see that these B cells will produce a lot of antibodies and some antibodies against spike protein, and then there will be some antibodies against the body's other tissues causing autoimmune-like disorder. You would also see that the B cells will get stuck in an unswitched state, which is also a state when a B cell is overstimulated, its machinery is going very fast, and it is not able to switch its class correctly, and it gets stuck in the unswitched state. In the unswitched state, this B cell would produce a lot of immunoglobulin, causing autoimmune-like disorder. But this really is a dysregulated immune system because of the overstimulation. The naive T cell, in the presence of interleukin 12, which is usually released by macrophages and dendritic cells, will become, this naive T cell, will become T helper 1 cell. And that is also CD4 positive. T helper 1 cell would then release certain cytokines and cause these CD8 positive cells or cytotoxic T cells to become activated, which would start killing those cells that are expressing the offending agent, for example, spike protein in this case. These cytotoxic T cell or CD8 positive cells also can have tumor necrosis factor alpha that is present inside of them, and then it can be released from them. Now, from the bigger picture, before we look at the text, here is the takeaway. The helper cells, T helper 1, T helper 2 cells were reduced. They were observed to be reduced in this study. The B cells were observed to be stuck in an unswitched state. The cytotoxic T cell were observed to be in an exhausted state. Now, the B cell stuck in the unswitched state is an example of overstimulated B cell. It is also an example of a germinal center damage to the lymph node. So the lymph node has tiny areas, which we call them germinal centers, where various cells are produced and they live there and they function there. Sometimes those centers, the lymph node parts, can become damaged. When they are damaged, they do not produce correct type of cells. And so B cell stuck in the unswitched state could be because of the germinal center damage. And that could happen if, for example, the inflammatory or offending agent has caused enough inflammation within the lymph node as well that the lymph node itself got damaged. And then the exhausted T cell, cytotoxic T cell, exhausted, actually does not mean that it was just, it is lying down somewhere and saying, hey, I'm exhausted like we do. In fact, an exhausted T cell means it is so overstimulated by the need of its work that it has finally become exhausted and is not able to function more. Such cells are actually still active. They are still trying to do the cytotoxicity or killing the other cells, but they are also exhausted as well. The T helper cells that are reduced in number are possibly because of the T regulatory cells that are trying to calm down the dysregulated immune system, that are trying to bring the overactive immune system back in control to say, you need to stop. And in that process, the T helper cells can reduce. That is one possibility. The other possibility is that the germinal center damage can result in T helper cells to be produced in less in number. The third possibility is that when T helper cells are overstimulated, because of the continuous presence of the antigen. For example, in this case, spike protein, these T helper cells change their lifespan and they burn out fast. All of these are actually an example of dysregulated overactive immune system, overstimulated immune system, instead of an HIV-like situation where the immune system is just not working correctly because it is not strong enough anymore. Okay, so back here, what you'll see is reduced memory CD4 T cells. So those T helper 1 and 2 and their memory cells, they are reduced in number in the post-vaccine syndrome patients. Number 2, increased tumor necrosis factor alpha CD8 cells. So these are these cells which I just mentioned. They were increased, and not only increased, they were exhausted as well. And that is a pro-inflammatory, overstimulated state and the result of that. Increased non-classical monocytes. So on the innate side, the monocytes, the non-classical monocytes, which are usually considered to be anti-inflammatory, but more importantly, the non-classical monocytes are present on the boundaries of our blood vessels and the tissues, and they patrol those boundaries, and they make sure that if there is something coming from the blood into the tissue, imagine blood-brain barrier. So if something is coming, some offending agent is coming from the blood circulation into the brain tissue, these patrolling monocytes, non-classical monocyte, are standing at the boundaries like a defensive unit to try to capture those offending agents and remove them. So non-classical monocytes were increased, which is another example of an overstimulated immune system with this continuous presence of spike or other offending agents, and those monocytes are now active. Then reduced conventional type 2 dendritic cells. So the dendritic cells over here, the type 2 dendritic cells, were reduced in number. Once again, that is not an example of the immune suppression, but instead that is an example of cells who are consumed by overstimulation. Then the lower anti-spike antibody levels. In the post-vaccine syndrome patients, the antibodies against the spike protein were lower. And the researchers thought that the reason for that is that because these patients became vaccine injured, they stopped having further boosters or further vaccine doses, which caused a reduction in the vaccine related antibodies. And that makes sense. If you have watched some of my other videos, you may have seen that what happens is that as an antigen is introduced in the system, let's say in this case spike protein, initially the very first exposure will cause immunoglobulin M to be presented, to be produced. Then it goes down within a week, 2 weeks, 3 weeks time. Then immunoglobulin G, which is the long-term immunoglobulin that is produced. In case of COVID, IgM and IgG are produced simultaneously because of the COVID spike protein's intense effect on our immune system. And then what happens is that IgG continues for a longer time, for many months, and then that wanes as well. And then if somebody takes a booster, then the IgG level will go up again, and then they would wane again, and so on. So normally 3 to 4 months. And this 3 to 4 months of IgG going up and then waning is not a specific behavior of COVID or spike protein related antibodies. This is actually the behavior of all immune responses, that IgM comes in first, then IgG comes in, and then it stays up and high for some time to make sure that the body is defended if there is a recurrence of the offending agent. And then over time, within a few months, these antibodies, they wane. And that is a normal behavior and a correct behavior. If the antibodies will not wane, if they will not go away, then our body would become a milkshake of antibodies from our young time to whatever our age is, and our body will be continuously hammered by the immune system and antibody causing activation of complement system. And this is the kind of problem you'll see here in the post-vaccine syndrome patients, that presence of spike protein or dysregulated immune system causes the B cell to stay active, which causes them to produce antibodies, which causes tissue damage as the antibodies settle in the tissue, and then the complement system becomes activated and inflammation occurs. This is not like HIV at all. Then you will see in this paper that EBV, Epstein-Barr virus, is reactivated as well. And so the Epstein-Barr virus reactivation that you would see is related to the type of antigen you will see is related to B cell activation as well. And it also makes sense that as the immune system becomes dysregulated after, let's say, a vaccine or a long COVID, the B cells that are activated, B cells that are becoming memory B cells, they would go and live in the bone marrow of the patient. The bone marrow is where the other B cells and memory cells are present as well. EBV will be present in them as well. And as these newer B cells come over and they are active and they are releasing the cytokines, they can activate the other B cells that would in turn activate the EBV virus, which, when that virus is activated, would then impact the immune system work as well. And so you would see in these patients, the vaccine injury patients, a picture that overlaps between the vaccine injury immune profile and the EBV reactivation immune profile. And this is why there is a speculation that it is possible that these patients who are vaccine injury patients, if they're given antivirals to control the EBV, these patients may feel better. And finally, this is something that is really strange and intriguing and mysterious for me, is that in some patients, not all of the vaccine injury, in some patients, even after 700 days, the spike protein is present in their serum, the S1P, so the full length. And I also saw some very sensational messages around that as well, that this is the proof of genomic integration and the cells have changed, and that is just not, there is no evidence for that. So I probably cannot sit here and to say this does not happen, just like I cannot say this does happen. However, I can provide you the evidence to demonstrate that this probably is a very difficult situation to happen. So continuing, then the immune system dysregulation in post-vaccine syndrome patients. Once again, it is kind of a repeat of what I'm just saying. Reduced CD4 memory cells, increased exhausted CD8 cells, increased tumor necrosis factor alpha producing CD8 cells, which is a chronic inflammatory state cell. B cell changes, there will be double negative B cells that are reduced. Now, this is an interesting situation because in chronic inflammatory states, double negative B cells are usually increased. And what does that mean? What is a double negative B cell? A double negative B cell is a cell, a B cell that makes antibodies, right? Plasma cells. It has, normally the B cells on their surface have IgD, and they have the IgD marker on them. And similarly, they have another cluster of designation or some proteins on them that are called CD27, which is an indication of a memory B cell. And they saw that in these patients, the IgD marker on the surface and the CD27 marker on the surface is not present. So normally in the chronic inflammatory state, these two are present. So why in these post-vaccine syndrome patients, this particular cell type was absent is probably because of the overstimulated immune system and injured lymph node germinal centers. So then there is another possibility, and that these double negative B cells were not present because the immune system decided, because of this continuous persistent attack of the antigen, that the immune system decided to take less help from the adaptive arm and take more help from the innate arm. So there was a skewing of the adaptive arm to the innate arm. And this is my commentary. This is not part of the manuscript. I promise to you that wherever I'll present my speculation or my understanding, I will say this is Mubin and not the manuscript. So double negative B cells were actually reduced. Normally, you would expect them to be higher in the chronic inflammatory state. So it may be because of the germinal centers are defective. It may be because of the innate skewing that the immune system is skewed towards the innate arm. It may be because the double negative cells were actually produced, but they got very quickly exhausted and changed. Then the myeloid cell alterations. So myeloid cells are like macrophages, dendritic cells, monocytes, etc. These cells, as I said before, non-classical monocytes on the innate arm are increased, and then the dendritic cells were reduced. Then persistent spike protein. I think that you would appreciate that what I had done was gone over the whole paper and pulled together the summaries of the cellular and immune system changes so that you can actually see them on one slide instead of going through the whole paper and trying to connect the dots. Now, this is the interesting part. Persistent spike protein. In some patients, so if you look at this study, I'm going to go to figure number 5 in this study. I think it is on the page 23. Look at that. I remember the page and the figure. So this is the figure number 5. And if you see in this figure, this G part of the diagram here is showing this table, not infected 1, not infected 2, not. So these are those post-vaccine syndrome patients who did not have any evidence of recent infection, and recent could be many months and years. And how do they know this? Number one, if you see here in this area, infection self-reported was negative. That patient said, I did not get infected. And number two, anti-N IgG. So immunoglobulin against the N part of the virus was absent as well. So what happens is normally we try to differentiate from the vaccinated individual to infected individual by looking at the antibodies against the virus that are more than just against the spike protein. Because the virus has other proteins, we just look at the N protein, which is part of the virus as well, and see antibodies are present against that or not. If the N protein antibodies are not present, then we say that the patient was not exposed. Now, the patient may have exposed many, many months ago, but the body's response has stopped. And so that could also mean that we would assume that that patient is not exposed. So at least at the time of blood sample collection, there was no recent infection. So here, if you see, NI1 to NI16, these patients, look at the column here which says spike in circulation. There are 4 patients, number 1, number 3, number 4, I believe, number 5, and number 16. They have these little wobbly, thready like things, and these are the presence of the spike proteins. So 4 out of 16 had the spike proteins. So it's not necessary that everybody who is post-vaccine syndrome had the spike protein. However, this is interesting that some of them had spike proteins even after 700 days. And that is a curious thing. So now, what are the possibilities? Here, I want to then clarify one more aspect which people have been just going, they're just creating all kind of messaging there. So let's think about it, that where would the spike protein come from even after 700 days? So one possibility is that when the spike protein was generated by the vaccine, or let's go from the most easier, a recent infection could have contributed to the spike protein. But again, as I said, these patients were tested to not have a recent infection. So that is a possibility, but gets removed, eliminated. Second possibility is that the virus, the SARS-CoV-2, is present in some reservoir in their body. I remember that while I was doing the COVID discussions, I discussed that when we become asymptomatic after having an infection, the fecal matter can continue to show the parts of the virus even up to 60 days. So it is possible that the immune privileged sites of our body, for example, GIT and other areas where immune system does not attack that often, there may be the virus sitting in there. For example, in the GIT, the gene here was presenting Jean is one of the cool beans here. She was mentioning that there is a recent study that says that in the oral cavities, there may be accumulation of the SARS-CoV-2 that is just sitting in there. So it is possible that there is an active infection. It is also possible that there is a reservoir of the virus contributing to the spike protein. Then it is also possible that when the vaccine was given and the spike proteins were produced, those spike proteins ejected from the cells either because the cell got broken down by the immune system or the cells released exosomes. We have done this discussion as well. And not. So give me 1 second. Looks like my screen is not working correctly. All right. So sometimes when I'm doing the screen presentation, the pen stops working. So my apologies, going back to it now. So let's see. Yes. So sometimes the cells can actually bundle up whatever is inside of their cytoplasm and kind of release that in an exosome where the spike proteins may be present, and then those can leak out. Now, the problem is that the presence of the spike protein outside of the cell that had vaccine, for example, can be there for days, weeks, months. But thinking about that for years is a difficult situation, just that cell sending the spikes out. So that is a possibility, but that also is a curiosity that how could that happen for 700 days? Then there is another possibility, and that possibility is, as Dr. Bruce Patterson's work had shown, that the monocytes that pick up those spike proteins, the non-classical monocytes that are at the boundary of our vascular system with the tissues, those monocytes could actually pick up the spike proteins and not digest them correctly and start persisting. And how does a monocyte, which has a shorter, relatively shorter life, how can that be persisting for months? It is possible that that monocyte can actually turn off its apoptotic signal. Apoptotic signal means that the cell death signal. And I remember I had done this discussion before as well, that it is possible that sometimes an immune cell that has become overactive and it does not have proper control of its internal machinery may not be able to do all the right physiological things. So a monocyte that has an undigested spike protein in it is possible to continue to live for longer. But still, for that monocyte to live for 2 years is a wonder. So then another possibility could be that the spike protein that is generated at the time of vaccination could actually end up in various tissues. And now it is just sitting in those tissues. And as various inflammatory events occur, and as our immune system go and attack those tissues for other reasons, let's say an infection, those tissues may have the spike proteins that get released back into the circulation. Another possibility is that the pieces of mRNA may end up in the lymph node carried by the dendritic cells, and those mRNA pieces might be sticking around and may aberrantly end up helping produce more spike protein. Then a more conspiratorial possibility could be that the mRNA gets transcribed, reverse transcribed into the cell, and then finally become the genome, part of the genome of the cell, and then start producing the spike protein. That is an interesting observation in terms of possibilities, not observation. That is an interesting possibility. However, the problem is the following. So imagine that this is a cell, and this cell somehow got the mRNA integrated into its DNA. What are the possibilities? The spike, the vaccine, it does not have the reverse transcriptase in it. Reverse transcriptase is an enzyme that can pick up a messenger RNA, convert that into cDNA, and then that cDNA can become integrated into our nuclear DNA. The reason for that is that messenger RNA is a single-stranded thing and DNA is a double-stranded thing. So we cannot just stick a messenger RNA into the DNA. So that's just not going to happen. So first you have to convert that messenger RNA into a DNA-like structure, and then you have to push that into the DNA. So it is possible that the cell was infected with some virus. Viruses can contain reverse transcriptase enzymes with them, and that would help the virus take their DNA and try to integrate that into our DNA. So maybe that virus was present, and then the messenger RNA of the vaccine was given. Then that messenger RNA caused the reverse transcriptase of the virus caused the messenger RNA to become converted to cDNA, and then that cDNA was trying to get integrated. The problem is, number one, viral reverse transcriptase are very specific to the virus DNAs. They can virus RNAs. They cannot just simply pick up any random mRNA and try to convert that into cDNA. Even if they did that, the DNA integration needs specific sticky points on the DNA that would then be used to insert them like a cartridge into our DNA. And this messenger RNA converting into cDNA, having that cartridge-like sticky points and then getting into the DNA is just a very difficult situation to happen. But let's assume that did happen. Now imagine that this cell is something that has a DNA integration. That would cause that cell to start producing spike proteins, and those spike proteins would start appearing on the surface of the cell. If that happens, the immune system, the macrophages, the dendritic cells, the other innate immune cell, even the CD8 cells, they would start attacking this cell and kill it. So expecting a cell to have 700 days long life, while it also has the DNA, the messenger RNA converted into DNA, integrated into its genome, and then producing spike protein for 700 days and still escaping the immune system, will be such a far-fetched idea that I think, one, there is no evidence, and number two, mechanistically, it is almost impossible. So genomic integration is a possibility in theory, but in practice, it would really be a very difficult situation to do. So that means, what is the explanation of the spike protein present 700 days later? It is a curiosity. All of these possibilities are there. What exactly is happening is something that should be looked at. If I was the one to put together the study designed for this, what I'll do is I'll try to take the cells from a person, and including the immune cells and non-immune cells, for example, a biopsy of the deltoid or a biopsy of the lymph node, plus the peripheral blood cells, and look into them for any DNA integration, or do that in vitro study for that integration. There was one study that happened, but that study was these cells were heavily edited to allow that kind of integration to occur. So that was not very fruitful study. So that study could be done in vitro. That study can be done with the patient's tissues and then seen if their cells are actually producing spike proteins continuously. Another possibility of the spike protein is that when the spike protein is produced at the time of vaccination or long COVID, those spike proteins were then coated with the anti-spike antibodies. Those complexes are now stuck to various tissues, and from there they can get released. Normally, these complexes are cleared out by the macrophages that are present in the spleen, but they can settle, these complexes can settle on any tissue of our body. Mostly they settle on the blood vessels, causing blood vessel inflammation. They can settle on the kidney to cause kidney inflammation and damage. And then they can settle on the blood-brain barrier, etc., causing neurological symptoms. So these complexes could be sitting in the tissues and then slowly releasing the spike protein as they avulse from these tissues and get released back in there. All of this is my speculation. This is not in the manuscript, and this is just Mubin thinking aloud with you from the mechanistic learning that I have done from medicine and immunology. Then the EBV reactivation. The significant increase in anti-GP42 antibodies against the EBV surface protein in the vaccine injured patient indicate recent viral reactivation. And I also already mentioned that the viral reactivation is possible. Now, when the EBV viral reactivation occurs, one of the immune footprint, one part of that footprint is production of tumor necrosis factor alpha CD8 positive T cells. So these T cells, CD8 positive T cell, which are intracellularly producing tumor necrosis factor alpha chemical, these cells are actually produced when the EBV reactivation occurs. So maybe the presence of these cells is not actually a picture of the post-vaccine syndrome and actually a consequence of the EBV reactivation, or maybe it is a common finding for both kind of diseases. But this still is not an immune suppressed state demonstration. This is an overstimulated, dysregulated cell demonstration. Then the autoantibody findings. This is very, very interesting. So if you look at the vaccine injured patients, the majority of the symptoms that you would see in them are you could suspect that there is an autoimmune possibility. There is an attack by the immune system onto their own tissues. One way that these immune systems attack their own tissue is by producing antibodies against their tissues. So in this study, what they did was the researchers, they checked for 120 antibodies for standard autoimmune disease profiles. Not any new profile, but existing profile of 120 antibodies that are done to test for any other autoimmune disease present in a patient. So they ran the same tests. And what they found was that the anti-nucleosome IgM, that is an IgM, immunoglobulin M protein produced by the B cells attacking the nucleosomes of the cells, that was elevated. And secondly, anti-AQP4 IgA, that is the neuromyelitis or the myelin sheath attacking antibodies. These are the ones, the myelin sheaths are the cells that are wrapping our nerves. So these antibodies would be attacking the nerves, although the antibody type is IgA, which they say is a first discovery. Normally, the IgM or IgG antibodies will be found, but here IgA were found. Then the subgroup differences, I'm not too much interested in those, but still, just for completion's sake, the post-vaccine syndrome patients that were infection naive, that did not have a recent infection, they had lower general health scores. They had anti-spike IgG lower compared to those who were controlled that had more vaccine boosters and had higher number of IgGs, which I explained a little bit earlier. Elevated IL-7 and IL-21, that is a T and B cell activation. And again, that elevation does not mean immunosuppression, but instead overstimulation. And then altered endocrine markers. It is interesting that the growth hormone were increased in post-vaccine syndrome patients, and that could be, now this is Mubin saying it, that could be because of the growth hormone is released when there is a stressful state in our body to help with the body's anabolic functions. So this growth hormone release could be a neuroendocrine tissue damage, or this could be because of the chronic inflammatory state where the body is trying to repair that state by releasing growth hormone as well. Lower thyroid stimulating hormone, and I have no idea why that got lower. Then the post-vaccine syndrome and infected patients, they had a different set of antibodies that were increased. Then the long COVID patients and the post-vaccine syndrome patient, what was the difference between them? The shared feature of those both diseases is persistent spike protein. So that is shared. Then EBV reactivation is also shared in both of these diseases. Chronic inflammation is also shared pathology in both of them. The difference is that in long COVID patients had higher IgG against spike. Post-vaccine syndrome patients had lower IgG against spike. Long COVID patients had elevated IL-4 and IL-6 and CD4 cells, while the PVS or the vaccine injured patient, as I said before, had lower number of CD4 cells and of course lower interleukins related to them. Long COVID patients show lower cortisol and higher futin A, but that was not the case in the post-vaccine syndrome. So as you can see from this study, there could be an evolution, a beginning of diagnostic criteria to say if this is happening, if this is the kind of immune profile that is appearing in a patient, they may be of vaccine injury type. Then I have already discussed this, that is it something that is similar to HIV? Not at all. The only parallel that you could see is that helper T cells, memory helper T cells, CD4 positive T cells will be lesser in both cases. And in the HIV, the virus actually infects these cells and destroys them. But in the case of post-vaccine syndrome, you are seeing that there is an overstimulation of the cells, which then cause these cells to become exhausted or burnt out. So they're not virally destroyed, or they're not spikily destroyed. So that's a huge difference between these two profiles. Then this is very important to notice that HIV is a progressive immunosuppressive disease, meaning as more and more cells are destroyed, the immune system actually becomes less functional. In the vaccine injured patients, immune system does not become less functional. It actually keeps becoming potent and aggressive, and it keeps damaging their tissues. That's a huge difference between these two profiles. And similarly, in the PVS, the immune system is overreactive. Then the spike and the genomic integration, I've already discussed that. It is a real far-fetched idea that somehow the spike will become integrated. We'll see if, when the further studies come in related to this area, to see if that really happens or not. But I strongly suspect that if the spike was, genome was getting integrated and the spike was being produced by the cells, those cells will be attacked by the immune system, and the patient would actually be in a very scary state within a few months. And finally, some limitations of this study. Small sample size, 42 patients on the vaccine injured side and 22 control, or those who had the vaccine but then did not develop side effects. Then no comprehensive genetic analysis to identify susceptibility. This is a very important thing. And I don't think it was the responsibility of this research team to figure out who becomes vaccine injured. That's a very important thing to actually understand. I wish that the vaccine injury related research was going on for 3-4 years as this problem was occurring, to figure out more that who are the people who are susceptible to this. Is this genetic for them? Is this environmental for them? Are they taking some kind of drugs that are causing this kind of interaction? Do their immune system has some existing dysregulation on top of that when the vaccine comes in, or the spike protein, might be from long COVID, or the vaccine causes this problem? So that profile of the patient is never known. I mean, we have never acknowledged, and by we, I exclude myself, the mainstream medicine has never acknowledged that this happens. And so there has never been any studies around that. Then similarly, the study was focused on COVID-19 vaccine only. So they said we did not look into other vaccines and see what kind of effects they may have produced and what is immune profile when those vaccines have their side effects. And then it is also possible that the vaccine injured may have had asymptomatic infection or prior infection that was not seen. Similarly, long COVID patients may have had asymptomatic infections, etc. So that is not there as well. And then my own observation that the vaccine inclusion criteria, exclusion criteria, they may have been done, but they're not part of the manuscript. So generally, this is the state that is revealed by this paper. Is this something that should be sensationalized? I think this is something that if we just look at the fact, as I said before, reality is stranger than the fiction. We do not have to create fictions around this. We just have to look at these profiles, immune profiles, and then do more studies to figure out what is happening. And more importantly, start accepting that there are people who got injured, and then figuring out how to help them, how to support them, how to study them. I have seen that most of the injured patients are actually willing to participate in the learning of what is going on. So I think that is where we should go as a medical sciences, instead of continuing to shun and suppress this kind of knowledge. So with this, thank you very much. In the description of this video, there are some links for the Buy Me a Coffee or others. If you would like to support this work, you can use those links. Thank you, and I would see you again. Bye for now.